A very good morning to one and all. I was asked to talk about this topic of comprehensive cardiovascular risk reduction in diabetics. These are my disclosures. None of them are relevant to this talk. I also want to acknowledge people who have been kind enough with slides and help for this talk. So this is a topic, comprehensive cardiovascular risk reduction in diabetics, which can go on for an entire conference if you would, because this has become the front center focus of what we do in cardiovascular medicine as far as prevention itself goes. Recently, there was a statement in circulation which dealt with what are the components of a comprehensive cardiovascular risk reduction in diabetes, and I urge you to look at this in more detail because it would be difficult to cover all of it in the 10 minutes time we have. But overall, what you see are there are certain important aspects that you should consider. There's obviously your lifestyle changes, you have your cholesterol, diabetes changes, blood pressure management, smoking, all of that, which go into cardiovascular risk prevention. But in addition to this, we have to start thinking about societal causes and also social determinants of health and health equity. That part of it I'm not going to cover here because that again is more of a policy. I'm going to focus on what we can do as physicians in our daily practice as far as management of these risks itself go. And again, I will not focus on diabetes management because as our previous speaker and other speakers are going to do, they're going to talk about diabetes management, control of diabetes and prevention of cardiovascular risk reduction. So moving on, if you look at statistics over the last 10, 15, 20 years, and this is data from, again, our statistical update in AHA and ACC, what you notice is several of the cardiovascular risk factors over the last 20 years we achieve better and better care. Smoking, lesser. Blood pressure, better care. If you look at two things, diabetes and obesity, these two alone are not getting better. In fact, they're getting worse. So if you look at obesity, the prevalence is starting to go up, and again, morbid obesity is starting to go up, and hand in hand, obviously, diabetes also, the total diabetes is going up. So despite having made great upgrades or management of cardiovascular disease and prevention, despite the overall amount of myocardial infarctions coming down, despite better care and all of that, our overall incidence could be a lot better if we start targeting obesity and diabetes as a major players in this. Now, the other thing that has happened in the same time period is diabetes itself. If you look at the outcomes as far as diabetes go, these have started getting better. So if you look at this publication from New England Journal, if you look at the overall death, if you look at cardiovascular death from coronary heart disease and hospitalization, for all of them in the general population has been coming down, plus among diabetics has also been coming down. So gone are the days where we think that every diabetic is super high risk for cardiovascular disease, but we're starting to recognize and realize that not all diabetics are the same, and overall, even among diabetics, there is going to be a spectrum of risk. So it's important for us as practicing clinicians to identify who these higher risk individuals are. Typically, if you look at the ACC-AHA guidelines, what they've done is they've identified in each of these categories what are the high-risk individuals. These are what we call risk enhancers. Kind of, easy to remember. The easier way is longer the duration, it's a higher risk. And the other thing is if you're starting to have end organ injury, nephropathy, if you're starting to have retinopathy, PAD, any of those become higher risk, and those are the individuals in whom you want to be more intensive in your management. Lifestyle factors, consistently, obesity, physical activity, what have you, across the spectrum. If you're not physically active, if you're smoking, if you're drinking too much, your outcomes tend to be worse. So this we know very clearly. What we don't have is how best to address these lifestyle factors in making a big improvement. But what we know is if your lifestyle factors are poor, your outcomes are going to be worse. So this is something that we should emphasize to each of our patients when we talk to them, that lifestyle factors are important. This is a starting point. As far as cholesterol goes, the ACC-AHA guidelines, the most recent ones, what they've done is they've identified diabetes as one of your primary prevention targets. And what they've done is they've said if you're 40 to 75 years of age, everybody should be, among individuals with diabetes, and your LDL cholesterol is above 70, you should be started on a moderate intensity statin therapy. Now, in the higher risk individuals, the ones I talked about before, the ones with those risk enhancers, or if you have increased risk, you can consider that too. In those individuals, you would again target a higher intensity statin therapy if you need. Now, The European guidelines are also similar in which they stage the risk. In other words, the higher the risk, the more intensive your therapy goes. The subtle difference is the European guidelines have LDL cholesterol targets, while the US guidelines have thresholds above which you would start therapy. Now here you can look based on the score criteria and how your overall score and how long your duration of diabetes is, whether you have end organ damage, you start going into the low, moderate, high or very high risk category, and on the other side, you would start noticing what the LDL cholesterol targets for them are. So subtle difference from what the US guidelines are, but the same message: the higher the risk, the more intensive your therapy should be. The ADA guidelines, the American Diabetes Association, kind of is in between the both, but in general, moderate intensity statin therapy, but they also identify other individuals, 20 to 39 years of age, and people with multiple risk factors where you would target a higher intensity therapy. Now, as far as LDL cholesterol lowering agents, we have several of them: statins, ezetimibe, PCSK9 inhibitors, bile acid sequestrants, and bempedoic acid. Now, most of these have outcomes data that have benefit. Bempedoic acid just yesterday or today was announced that it had, they stopped their primary trial. Overall, they're all well tolerated, and if you look at all of these, statins, ezetimibe, PCSK9 inhibitors, among diabetics, they seem to have a better benefit when you do a sub-analysis. Statins alone have a specific study for them itself. As far as triglycerides go, a little bit more of a tougher issue. We know that it does increase your risk, but how do you treat it? The only study with some evidence supporting it was the icosapentaethyl study with REDUCE-IT, which showed a statistically significant reduction in outcomes. This is a little controversial, or at least there's some debate about what the placebo arm in this. They had mineral oil, whether what that contributed to it's still being debated. But overall, other studies also support icosapentaethyl as far as their reduction goes. So that seems to be a reasonable agent that you could use. Now, as far as blood pressure goes, as we've talked about with diabetes, in general, what you can see here is if you look at every risk range, less than 11%, 11 to 15, 15 to 20, or greater than 20%, this is estimated cardiovascular disease risk, at every risk range, your relative risk reduction is the same. But at your higher risks, your absolute risk reduction is more. In other words, potentially more bang for the buck. Right? So although your relative risk reduction is same, the absolute risk reduction is more, so your number needed to treat would be lower at these risks. So with this in mind, ACC/AHA guidelines have also started incorporating risk in your estimation of how intensive you should have blood pressure management. But among diabetics, when they've done a study where they did intensive versus non-intensive therapy, there was not a significant benefit whether you were intensively treated or treated with conventional therapy. So at this point of time, the American College of Cardiology and American Heart Association recommend 130 or less than 130 for systolic and 80 for diastolic, and the first-line agents being diuretics, ACE inhibitors, ARBs, or calcium channel blockers. Now, the American Diabetes Association target the blood pressure of less than 140 over 90, but in people with higher risk, less than 130 over 80, with a similar choice of medications, but moving ACE inhibitors to the top of the list as far as that goes. Now, smoking cessation obviously is important. Smoking cessation and the different options, nicotine replacement therapy, other pharmacotherapies, that we know of, all of these should be discussed with your patient, help them set a quit date, and this is an important part of what we can do because this is going to multiply their risk, cardiovascular disease risk, quite a bit. Varenicline is another one that's available, and that's another agent, useful agent for you to stop, for you to use for helping our patients stop smoking. Finally, just hitting home on aspirin. This has been another area of controversy of late. Originally, we used to say an aspirin a day keeps the doctor away. Then came on statins, and on top of statins, it was difficult to show benefit. The most recent study on patients with diabetes was the ASCENT study, which looked at aspirin in patients with diabetes mellitus. What it showed was that overall, aspirin did reduce cardiovascular events, but at the cost of increased bleeding. So if you look at the data, consistently, if you look at your rate ratios over here, any vascular event, aspirin did reduce it by about 12%. But the major bleeding was also increased by about 20%, as you can see, intracranial hemorrhage and things like that. Predominantly, GI bleeding was the one that was driving it. So if you look at overall, what you have to consider is the net benefit. So this is a place where I have a discussion with the patient, looking at what the relative risk and benefit is, what they have and what they want to do. Whether you want to save an ASCVD event at the cost of a GI bleed, this is something that you have to factor in. And this is where we're starting to go in risk prediction, identifying the highest risk patient who may have the most benefit for it. So diabetes I'm not going to cover, but this is a summary of what our previous speaker excellently discussed about the different options, looking at different things. But again, GLP-1 agonists and SGLT2 inhibitors as far as that goes. But remember, even with this, our residual risk remains. Here you look at it in the treatment arm with statins, the risk was higher than the placebo arm for a non-diabetic patient. So this is what we have as far as what the residual risk goes. So treating this is going to be important. Remember, at the end of the day, this is a team sport. We need our people who help with lifestyle. We need our people who help with diabetes management, cholesterol management, blood pressure management, and all of this together can help our prevent CVD. Thank you very much.